You know the feeling. A patient walks in with that nagging cough, the one that's been around for weeks. You've tried a few things, but nothing's really hitting the mark. It's frustrating for them, and let's be honest, it can be pretty frustrating for us too. But what if I told you there's a simple, structured way to crack the code on even the most stubborn cough? Well, in this explainer, we're going to build that exact framework, step by step, to turn that all too common confusion into rock solid clinical confidence. Let's dive in.
This quote, it really hits home, doesn't it? Because we know the shotgun approach, just throwing a mix of cough syrups and maybe an antibiotic at the problem, it just doesn't work. In fact, it can lead to side effects and even antibiotic resistance. So today, we're swapping that guesswork for a precise, diagnosis-driven strategy. By the end of this, you'll have a clear plan to sidestep over treatment, catch the serious stuff early, and manage every single cough with confidence. So, here's our game plan for today. First, we're going to really understand our opponent, the cough itself. Then we'll build our defenses by learning to spot those non-negotiable red flags. After that, I'm going to share a super simple diagnostic framework that will completely change how you think. We'll then put that framework to the test with the 6 most common culprits you'll see in your clinic. And finally, we'll pull it all together into a master plan that's going to make you an absolute pro at managing cough. Ready? Let's do it.
All right, first things first, let's lay a solid foundation. You can't build a house without a good blueprint, right? Well, in the world of cough, our blueprint is a really clear definition and, even more importantly, a smart way to classify it. If we get this part right, I promise you, the rest of the diagnostic process becomes so much easier.
This is such a critical mindset shift. See, the cough isn't the villain, it's the alarm system. It's the body's own intelligent protective response to some kind of irritant. So our job isn't to just silence the alarm with a random cough suppressant. Nope, our job is to be the detective who finds out what's causing the alarm to go off in the first place. When we start thinking like investigators, we're already on the path to effective treatment.
This right here, this timeline, is your first and honestly your most powerful diagnostic tool. The simple question, so how long have you had this cough, immediately cuts your list of possibilities in half. A cough that's been around for less than 3 weeks, that's acute, and you're thinking infections, like a virus or maybe acute bronchitis. But a cough that's been dragging on for more than 8 weeks, that's chronic, and that opens up a whole different playbook. We're thinking asthma, GERD, or post-nasal drip. This one question is where the real investigation begins. Okay, so before we put on our detective hats and dive into our frameworks, we have to do the most important thing first. We have to make sure the scene is safe, and that means actively screening for red flags. These are the signs and symptoms that tell us, hey, this might be something much more serious than a simple cough. This step is an absolute must-do every single time, no exceptions. Think of these as your absolute stop signs. The moment a patient mentions any one of these, you hit the brakes. Coughing up blood, losing weight without trying, drenching night sweats, these aren't just symptoms. They could be signs of something really serious like a malignancy or TB. Your next move isn't writing a prescription. It's ordering a chest x-ray and thinking about an urgent referral. When it comes to red flags, we don't wait and see, we act, and we act fast. All right, we've secured the perimeter and ruled out immediate danger. Now it's time to start our real investigation. And listen, forget trying to memorize a huge random list of all the things that can cause a cough. That's like trying to find your way around a new city without a map. Instead, I'm going to give you a simple, elegant system, a kind of GPS for diagnosing cough that will guide you straight to the right answer. That's it, just 4. The entire universe of common cough causes can be neatly organized into just 4 logical categories. This number is the key. Remember these 4 buckets, and you'll always have a solid structure to fall back on. And here it is, the 4-bucket system. It's basically an anatomical approach. So with every patient, you just mentally run through this list. You start at the top with bucket 1, the upper airway. Is there something dripping down from their nose or sinuses? Then you move down to bucket 2, the airway. Are the bronchi themselves inflamed or tight, like an asthma? Next, you go even deeper into bucket 3, the lung parenchyma. Is there an infection right in the lung tissue, like pneumonia? And finally, the one that's so easy to miss, bucket 4, the non-respiratory causes. You look completely outside the lungs. Could it be a medication? Or could it be acid reflux from the stomach? By running through this checklist every time, you become systematic and you're way less likely to miss something important. Okay, our next diagnostic filter is the character of the cough itself. Just ask, is it a dry cough or are you coughing anything up? This one question gives you a massive clue. A dry, hacking, irritating cough usually means, well, irritation. Think a virus, allergies, or maybe a little puff of stomach acid. But a productive cough, one with phlegm, that points more towards inflammation and infection, where the body is actively producing mucus to fight something off. It's simple, but it's a really powerful way to narrow things down. Now we're really getting into the detective work, looking for patterns. The timing of the cough can be a dead giveaway. Does it wake them up from a deep sleep in the middle of the night? That just screams asthma. A hacking, productive cough first thing in the morning? That's the classic smoker's cough you see with COPD. And a cough that shows up like clockwork about 30 minutes after they eat? You have got to be thinking GERD. The patient's story is filled with these clues. You just have to know what to listen for. Now, just let this number sink in for a second. 70%. That means 7 times out of 10, you can get the diagnosis right without a single test. All you need is a good systematic history. What does that tell you? It tells you that your most important diagnostic tool isn't your stethoscope or a lab request form. It's your ability to sit down, to listen, and to ask the right questions. Master that, and you've mastered the cough. Okay, theory is great, but let's get practical. We've got our framework. We've honed our detective skills. Now let's put it all to the test with the usual suspects, the top 6 most common causes of cough that you are going to see day in and day out. Let's meet the lineup. First up, the undisputed heavyweight champion of coughs, the common viral infection. You know this one: dry cough, runny nose, maybe a scratchy throat, and when you listen to their chest, it's totally clear. Now, your most powerful tool here is not an antibiotic, which will do absolutely nothing. It's your ability to educate and reassure. A simple explanation about how viruses work, plus some advice on symptomatic relief, is truly the best medicine you can offer. Next up is the silent culprit of chronic cough: post-nasal drip. This is the one that so many of us miss because patients don't say, "I have a drip." They say, "I have this constant tickle in my throat." But if you hear them clearing their throat over and over in your office, or they mention a cough that gets way worse when they lie down at night, this should jump to the top of your list. You have to ask about it directly. You know, asthma can be a real master of disguise. We're all trained to listen for that classic wheeze, but sometimes its only calling card is a cough, especially one that acts up at night. This is what we call cough variant asthma, and it's a diagnosis you just can't afford to miss. So if a patient has a recurrent dry cough that's waking them from sleep, you have to think asthma, even if their chest sounds perfectly clear in the clinic.
And now for a cause that has absolutely nothing to do with the lungs: GERD. Picture a tiny little volcano in the stomach that's silently erupting, sending microscopic droplets of acid all the way up into the airway. That chemical irritation can trigger a really violent, chronic cough. The big clues: a cough that's worse after meals, maybe some heartburn or a hoarse voice. Often a simple trial of a PPI for a couple of weeks can solve the mystery.
Acute bronchitis. This is the trickster of the cough world. It often shows up with a productive cough, sometimes with greenish sputum, and that just makes everyone, patients and doctors alike, jump to bacterial infection. But here's the thing: over 90% of the time, it's viral. So here's the rule of thumb. Unless the patient is very elderly, has other serious lung issues like COPD, or is showing signs of pneumonia, just put the brakes on the antibiotics. Resist that urge. And finally, the diagnosis we can never, ever afford to miss: tuberculosis. If you have a patient with a chronic cough, plus any of those classic systemic symptoms, losing weight, drenching night sweats, a low-grade fever that just won't quit, your internal alarm bells should be ringing off the hook. This is not a wait-and-see situation. This is a get a chest x-ray today situation. Early diagnosis is absolutely crucial.
So, we've met our usual suspects. Now, how do we actually build a definitive case? Well, that's where smart investigation and treatment come in. And the goal here is to use tests wisely, mainly to make sure we're not missing anything dangerous, not as a crutch because we're not sure. And our treatment has to be targeted and effective, not just a random shot in the dark.
I want you to look at this slide as a pre-mortem of a badly managed cough. These are the classic, common mistakes that can send us down the wrong path and delay the right diagnosis for weeks, even months. By just knowing what these traps are ahead of time, we can build a system to actively avoid them. Think of this as your clinical checklist of what not to do. All right, it is time to put all the pieces of this puzzle together. We're going to build your personal cough algorithm, a step-by-step master plan that will guide you through every single cough consultation. This is what will make you faster, more effective, and most importantly, safer in your practice. For an acute cough, your algorithm is beautifully simple and fast. Step 1, always start by ruling out those red flags. Step 2, If there are no red flags, you assume it's viral. Treat them with reassurance, tell them to drink fluids, and maybe suggest some simple symptomatic relief. Step 3, if it's a productive cough with a fever, you can consider bronchitis. But remember, hold off on the antibiotics. And step 4, your crucial safety net. Always give clear follow-up instructions. Come back if you're not better in a week or if you start feeling worse. Simple as that. Now, for a chronic cough, we need to be a bit more methodical. Step 1, rule out red flags and get that baseline chest x-ray. It's non-negotiable. Step 2, systematically run through your big 4 mental checklist. Could this be asthma, GERD, post-nasal drip, or even TB? Step 3, based on the patient's story, form your best hypothesis and start a targeted therapeutic trial. Think of it like a clinical experiment. If you suspect GERD, try a PPI for 2 weeks. And step 4, which is so important, schedule a follow-up to see if your experiment worked. This diagnose by treating approach is an incredibly powerful tool. And finally, just a few pro tips from the real world. First, reassure, reassure, reassure. Your confident reassurance is often more powerful than any pill. Second, avoid that shotgun therapy. Targeted treatment based on a good diagnosis is always better. Third, manage expectations. A patient might come in wanting an antibiotic, but a throat lozenge and a good explanation of why it'll work better is far superior medicine. And fourth, always provide that safety net of clear follow-up advice. It's a non-negotiable part of every single consultation.
So here's the bottom line. A structured approach turns what feels like a chaotic problem into a completely solvable puzzle. A cough isn't inherently difficult. It only feels that way when we don't have a system. So master the framework we've talked about today, the timeline, the red flags, those 4 buckets, and I promise you, you won't just become a better clinician. You'll also find a whole new sense of satisfaction in tackling this super common complaint. Now go out there and be the confident, cough-conquering doctor your patients need. Thanks so much for watching.